No, just I was looking for, the discussion is so lengthy and take minutes.
Yeah, we have time till 9:30, so it's only 9:20. Yeah.
Okay.
So I should apologize to the speakers who have come ready for the biopsy stuff. I think that is again going to attract a lot of discussions from the poll which Vinith took. I think we can end up this session with Vinith showing the poll which he took for biopsy, then have the discussion in the next month. Yeah, quickly, wait.
Thank you, sir. There's a two. I'm audible, sir.
Yes.
Yeah, this specifically preferred for this forum. So this is my. I take some 10 minutes. That only I'm just going to show video presentation of my left side insertion. This is what I just made up some kind of easy to understand delving point, direction, and depth, and a dawdle forward. That is a slow movement moving forward. Just I'll demonstrate in the video, and the final destination. Manish has little made my job easier because this is what anatomic position I always look at it. This is the Zippy sternum. I look at the Zippy sternal point, which is palpating the Zippy sternal junction is very difficult, but over the experience, I think one can find out that the Zippy sternal junction is almost touching the fifth rib and just above the area where I just want to place my final position of my catheter tip. So this is what always I look at the bedside. The catheter I just going to show to the insertions at the bedside one, and quickly I move into that. This is an anatomical landmark. I learned a new point from Manish that I'll go for a calculation hereafter. But this is so far this I've been using Zippy sternal junction, not Zippy sternal bone. Zippy sternum and junction is the just a draw line which is touching the fifth rib. Just above one or two finger will be the my tip position. This is what I just go quickly, sir. This is all video. I'll just 10 seconds. So this is what the insertion is thing. Before doing this, I just had ultrasound in imaging, and I just ruled out everything about any the patency of the veins and everything. This is just a superimposed the image, same thing. The point is, I'm going through the usually posterior approach or supraclavicular approach. The downside of the angle is the external jugular vein, and the below one is the clavicle, and medial is the internal jugular vein. The exact in the middle, I draw a point, and through this point, I insert a needle, 45-degree angle. So definitely one can hit only the vein. So this is the guide wire inserted already in situ. Just putting the tunnel. Record inside I'm inserting. So just rapidly go through. This is the way I just before inserting my catheter, I'll just have a road map. And I already told you Zippy sternal, the point is where the tip my final position. This is the exact angle I'm looking forward after the insertion.
Well, to interrupt you, how are you sure the guide has gone into the SVC and right atrium?
No, the next video I'll show you, sir.
Right subclavian vein.
Yeah, next video I'll show you, sir. Next case I'll show that. So I'll tell you, sir. So I'm pulling the catheter out. I'll just skipping this. I already catheter is out. Now I'm putting the dilator. Screwing motion, sir, that is always fun, and never poke it directly. I just make a screwing motion. So now I'm putting the feeler sheath. This is a catheter I inserted 2 days ago on bedside. So I'll select a very clean cases because in my center, there is no access problem. The one patient comes next day, I'll create a fistula. So very rarely I get from outside patients all this access issues. So if my patient prefers to go on TCC, for example, if a patient is in a near close, have their transplant fixed for down the line next 1 or 2 weeks later, or 1 month, during the process of a legal thing and evaluation process, I put a tunnel dialysis catheter. Otherwise, I'll go for next day after a non-cuffed catheter temporary one, I'll make a fistula. So in my unit, the access issues are very minimal. So this is what after keeping one more time, just check whether I'm in the exit point. I'm in a Zippy sternal joint area, just 1 centimeter or 1 or 1.5 centimeter above. Exactly, it will be in the mid right atrium. So I'm just putting the inserting the catheter, split catheter. So most of the time I do single-handedly. So that's what I've been attuned to. So I've taken all close images. One can watch very, how things are done. So soon after this, I'll have a digital X-ray and I'll take it. I'll see the final position. Then I'll make 1 or 2 centimeter adjustment on the tape. I mean, the bed itself. So that's the way I'm doing practice in my center. It's my center is a standalone dialysis unit. So after that, I'll see this is the most important one. I'll see a gush of blood is coming out when I use a 20 ml, 10 ml syringe. So I'm pretty sure that this is going to be a good on machine.
Well, actually, time and again, I mean, not very frequently, but the guide wire gets, when it in the junction between the right brachiocephalic and the SVC and the left brachiocephalic there, and again we may have difficulty.
After the second case, you can please make a comment, because this video I cut short because the time is getting short. I just removed 1 or 2 videos there, and I'll show you the next case. I'm going to the next case there. So this is a final position. So this is the final one. Soon after finishing the procedure, I took X-ray, and this is the final position of it. And soon, immediately afterwards, I started dialysis and sent them home immediately. So this is another case. I'll just go. The posterior approach. All the 2 cases are generally I prefer putting tunnel dialysis in posterior approach. Again, the angle is the medial inferior. That is the lateral part of the sternocleidomastoid mastoid. Down one is it's the external jugular vein, and below one is the clavicle. So this is exactly middle. You hit 2.53 centimeters, you can get the vein, or it may be a junction of subclavian with the inferior jugular, or it could be even subclavian, or it could be a distal part of the jugular, anywhere between that is where the puncturing point could be. So this is now you can see that I'm just putting the guide wire slowly and going. As Manish mentioned that when guide wire is getting stuck somewhere, or I find any kind of resistance, I'll always think 3 times, 4 times, 5 times before inserting the guide wire and subsequently the dilator. So that's what the sense I've developed over the years. So guide wire should go smoothly inside, and next video I'll show you. And I'm just pulling the guide wire back and forth. I see whether it's in a smooth course. So this is what I make sure that I'm in the right, I'm in the inside the left innominate vein, and so I'm putting the video little twisted actually it seems, and I'll next, and I'm just pulling the. So now I'm just inserting the peel away sheath. So this step also very important. I'll insert very carefully. I'll go back and forth, back and forth. As soon as I hit the vein and I comes some kind of the given feeling. That's all the sense I developed over the years. And once you pierce the vein, some kind of subtle the sensation I feel from the finger will go to the neocortex, and I have some kind of sense. I'm confident of going further. I'll never give any pressure. When I go slowly, I insert the sheath, the peeling away sheath very gently inside. That's what I call dexterity in inserting this. Then I put the rest of the story. Then you can put it down. The moment I finish, I told the girl to keep X-ray ready. So we have figured the digital X-ray, and that's the only bedside thing I have in my unit. And soon I'll take it and find out a position. If there is something down or up position, I'll just try to adjust it on the bedside table itself. That's the way this is the flow. So when with pressure I pull it, it should come freely. So this is what the positions. So finally, again, I'm coming to the point. Ziphus tunnel point is the Ziphus tunnel junction, is the 5th intercostal space. I mean rib. just above one finger. It all, if you do 3-4 catheters, most of the time we never miss that position. So we save time and we can start immediately on the patient. So SVC enters the mediastinum in the carina. It's a Lewis angle. This is T4, T5. CA junction is a 2 vertebral below the carina. So this and all, the CA junction, there's a cavoatrial junction, and identifying counting the costochondral areas would be, even Lewis angle is very easy. So subsequently, if a patient is obese, you cannot run down the finger palpating exactly which costochondral junction you are in. Rather, you can go for a rib, you can count the space, and with that space, you can mostly fourth intercostal space, a little down. There's upper part of the fifth rib, lower part of the fourth intercostal space. It's almost equivalent to the point you draw across the xiphisternal junction is where my position would be. And most of the time, I never miss this way. This is a left side catheter. Even right side, generally I go with this. Finally, makeup. This is applicable only in my opinion. If you go through the posterior approach, supraclavicular approach. If you go to the anterior approach, I think there must be some kind of overshoot, undershoot, and I'm not. But I'm just doing last 10-15 years only the posterior approach, and this is what the catheter position. Finally, the catheter position comes smooth, and the thing is, the moment you insert the guide wire, the guide will give me a lot of idea whether I'm in the right direction, I'm in the right path. The guide wire should go very smooth. That's where any kind of resistance, I always withdraw the procedure and just abandon and just wait for 1 or 2 days and make up my mind very clearly and go with echo other things. So I'll send it to fluoroscopic insertion. So most of it doesn't happen because the only patient referred from other centers to my center, then I may be using that. Otherwise, if the clean patients coming to me, if they're requiring TCC, this is the way I do. So thanks, sir.
Thank you, Vail. Actually, one great advantage of this lateral entry, which Vail demonstrated just now. So the issue of tunnel catheter bending, because if you come from above through the internal jugular, it takes a turn, then it might have this difficulty. But this lateral,
I'm running the slides as you speak. I run through the slides, sir. Okay.
Yeah, so that gives that advantage. See, he is pushing the tunnel catheter straight into the
exactly.
I think that's a great advantage of this lateral entry. But what if at the end of the day, if you see the X-ray showing the tip in some other position, the cuff and all?
Not end of the day, sir. End of the procedure, sir. I'll come to know, sir. I'll come to know immediately. We have I acquired a digital X-ray unit, and just a very, very portable one, sir. Immediately you can find out. Then I'll just make quick adjustments, sir. And either I pull it down or through that the first incision I made in the entry point, I'll just pull it using a curved artery. I'll make some adjustment.
Realize that Vail is very adept in using the echo probe. So
yep.
So he is great in both. So not everybody is good at using ultrasound.
But I found, sir, because having done many times echo, but it's a lot of fallacy inside, sir. You can't be sure 100%, sir. And either, as you said, fluoroscopy is the ideal one. You can identify the tip. But this is a good landmark, and it saves my time. And this is why I practice. I think after seeing I think I will be under fire. That's why I given message to that. Any comments, please send to my personal number. This is a modern era. I should use modern gadgets and technology. And this may be a wrong guidance to young people, but this is why I practice. I just given my ideas over here. And I think the young guys should take up the experts, what they said initially.
Yeah, it was always good to know, all possibilities, the skills from others. And I think, I think it's 9:30. And I thank. Any other quick comments from anybody?
I just wanted to say, he's doing it so often. It is when you dilate, that's when the problem starts. And so I've seen many of my fellows, when they dilate, they'll push the dilator all the way in. And especially if you do it on the left side, you need fluoro because you want a straight angle. Now, Vail has got a smooth curve, but that is not always the case. So I was very nervous watching him do it because I've seen things go wrong when you dilate, especially from the left side, not from the right side.
Because he's going from the lateral approach, he gains that advantage of a smooth curve. And when you share your screen, and I want you to just project the poll for
Sir, can we do it
biopsy.
next time, sir?
No,
Can we do it next time?
just the poll result of the, so that it will be a prelude to the next interesting meet next month.
Yes, sir.
How many doing biopsy themselves or giving to IR, that will make them keep thinking before they come for the next meeting.
Yes, sir. Just
sharing. See, if you are doing jugular on the left side, and the guide wire is going down, then it usually will enter, because the axis of that guide wire or the axis of that thing is directly entering the superior intercostal vein. The superior intercostal vein will ultimately communicate with the SIGO system, and so that is a wrong placement. The catheter, the temporary catheter will go down, perpendicularly down. It need not be necessarily the left-sided superior vena cava. It can be the left superior intercostal vein. To study the anatomy of that SIGO system, that is a very important vein, and the alignment of that vein is right opposite the left in IJV.
Yes.
So we have a very interesting discussion coming up next week. So we try to see that who all nephrologists are doing biopsy. And in fact, all 100% felt, most of the people felt that the nephrologist should be doing the biopsies, both native and graft. And around 20 or 23 people felt that either one of them should do, either a nephrologist or a radiologist. So we went ahead further, and at that center, how many are actually doing, we tried to find out, and found that 110 of the most of the nephrologists are doing for both kidney, and that is native kidney and graft kidney. And in most of the centers, what they are doing is that the simple cases or the native kidneys, it is done by the nephrologist, whereas the high-risk complex cases or sometimes graft biopsies in some centers, that is being done by the radiologist. And very few centers, the intervention radiologists are doing most of the biopsies. So we have an interesting discussion coming up next week, in which we'll discuss various special situations or difficult cases of biopsy.
Right. Thank you. Okay, is there any comments from any others?
I think
Venki here. There's one question I wanted to ask Dr. Vail. I think he has left. I can ask you, sir.
Yeah, sir, I'm just leaving. Sorry, please. 1 minute, I'm just leaving. Yeah.
So it's little unrelated to whatever you discussed. I saw the placement of left side. When you place the third dilator, I saw once it has entered the vein, you are passing only the peel away, keeping the whole dilator outside. Is that so, sir?
Yeah, peel away. See, I just want to. I don't want to go the whole length of the peel away sheath inside the vein, right?
Yeah, understood. But does it go all that smoothly all the time, sir? Like only the outer peel away?
It's going very smooth. Right? See, I tell you this: if you just beside me and just understand the real feel of have a direct witness of what we are doing, then you can get it. But from I went very fast now. But as Bala sir said, I'm just going very parallel to the vein, almost parallel to the vein. It's going very smooth, Venkatesh.
I don't think it matters whether we
have to take the bend.
And
if you go from anterior approach, that is always a problem, right? If you go this approach, I think that there will be a. I think if you have any resistance, I'll go back and come again, and then I slowly, gently, just millimeter, I inch forward. I'll never just push it very hard.
Okay.
So particularly at the area where the brachiocephalic takes a bend to the SVC, don't you need that support, sir, for the peel away to get down?
I think
his peel away went up to the full length of the denominator,
not beyond that junction. I think that junction will go. I think that's what I presume at the time.
Okay. Thank you, everybody. And we had some guests from outside also. There was Naval Rahman from Mexico. Is he around? You can unmute him if he's there, Karthik. And our friends from Malaysia.
Hey, Deepan.
Yeah, I hope.
Deepan, I think he's left.
Right. Okay.
Sir, I have to leave, sir. Bye, sir.
Right. I think it's time for everybody. I think there's a lot of things coming up in the chat box. I don't know whether every question had been answered, but we'll. Dr. Suresh, you've been very quiet today.
it's a very interesting thing. I think my opinion is it's always nothing wrong in learning new things, and you should be skilled in doing everything. And the ultrasound is a very excellent tool, and I use it a lot. And we all learn and improvise all the time. And there are situations when we have to do in the bedside or whatever, and we should be ready for the task. So especially if you're doing interventional nephrology, it's an opportunity always to learn and get experience with it. So I have no problems in using ultrasound for doing these procedures, because I use a lot of these ultrasounds in my practice. So it's a very good presentation, and I've frequently seen Whale presenting this many times. It's basically, I do always posterior approach, as he said, and then I don't stick the interjugular vein acute angle. I go to the side, so it will take the bend and you don't get kink. So it always goes with the flow. So I'm excited that you all presented this to the arena, and so everybody can know and learn about this.
Thank you.
Sir, one last comment, sir. Sir, I think science and medicine both are changing and evolving. So what is standard of care today, or what was standard of care yesterday, may not remain in future. So it is very good to imbibe new things and learn and take it forward, sir. Maybe a few years from now, the things might change.
That's true. We have to learn.
Let us see, sir.
Yes.
Yeah. With handheld ultrasound and all coming up, so things might change. So it is, as you said, we should upskill ourselves in all aspects. I think I thank everybody, the seniors, Professor Kasi, Dr. Anil, Vandana, and Suresh and Adrian, and everybody who has joined today and made the whole event very interesting. And I think the final word can never be said. So let us get equipped more and more with the newer skills and make ourselves more confident and do the right thing for the patient. Thank you, everybody. I think we'll close the meet. And the next month it will be renal biopsy in different situation. I think that is again going to be very interesting. So let's await that. Thank you.
Thank you. Good night.
Thank you. Good night.
So good night, sir.
Good morning.
Thank you.
Good day to Anil.